So today we'll be continuing the review of GT15 from question number 51 to 100, which is supposed to be the second part of Grand Test 15. So starting with the question number 51, a 62-year-old male with a history of uncontrolled type 2 diabetes mellitus presents with significant thickening and yellowish brown discoloration of his two nails. Clinical examination and KOH microscopy of nail clippings confirm the diagnosis of dermatophytic onychomycosis. Which of the following is considered the most appropriate first-line treatment for this patient? So we can see that the risk factor given in the question is the patient is having diabetes mellitus. And also the clinical features have been given. There's thickening and yellowish brown discoloration of his toenails. And the diagnosis has also been given dermatophytic onychomycosis. So dermatophytic onychomycosis is commonly known as nail ringworm. And now if we talk about the treatment of dermatophytic onychomycosis, the drug of choice is oral terbinafine. This is the first line management for this infection. And also if we look at the treatment in detail, we can see that terbinafine is the drug of choice, but the duration differs for fingernails and toenails. So the duration of terbinafine, which has to be taken orally for fingernail infection, is 6 weeks. And for toenail infection, it is 3 months. And the other first line drug for dermatophytic onychomycosis is oral itraconazole. The oral itraconazole has to be taken for 1 week or 1 month for 2 to 3 months for fingernails. That means it will be taken for 1 week per month for fingernails, and it has to be taken for 3 to 4 months for toenail infection. And the second line drug which has been approved for this condition is oral griseofulvin. So griseofulvin has to be taken for a duration of 4 to 8 months. And this duration can be extended for toenails. So longer duration is required for toenail infection. And we also can see in this picture the classical findings in dermatophytic onychomycosis. We can see that there's yellowish discoloration of the nails, and also there's thickening of the nails here. And this green arrow shows a tunnel which has been formed in the nail. So coming to the options, oral ketoconazole, no. It is not used in onychomycosis. Oral terbinafine is the drug of choice, followed by oral itraconazole and topical cyclopyrox. This drug has very poor penetration. And for this very reason, we are not using this drug in the treatment of this infection. And then coming to the option D, that is oral voriconazole. We know that voriconazole is used in invasive infections. For example, we have invasive aspergillosis. Then coming to the next question. The question says match the following. So we have been given 4 conditions, that is vocal cord palsy, Parkinson's, bronchogenic cyst, and tracheal stenosis. So in bronchogenic cyst, there's variable intrathoracic obstruction. So there's flattening of the expiratory limb, and there's relatively preserved during inspiration. And that is represented by the image 4. We can see that the expiratory limb is flattened and the inspiratory limb is preserved. So this represents bronchogenic cyst. So bronchogenic cyst is represented by the option 4. And then coming to the tracheal stenosis. So in tracheal stenosis, there is classical box-shaped loop. That means both inspiratory as well as expiratory limbs will be flattened. And it is the characteristic finding of fixed upper airway obstruction. So the tracheal stenosis will be represented by the figure number 3. So looking at these options, we know that option 1 will be correct. That means the sawtooth vocal cord palsy is represented by the graph number 2, which is blue in color. And then Parkinson's disease will be represented by a red color graph, that is sawtooth appearance. And bronchogenic cyst, which is option C, will be represented by the graph number 4. And tracheal stenosis, that is D, will be represented by the graph number 3. So matching these options, we have reached the answer A, option A. Then coming to the next question, a male patient presents with gait abnormality. He has sustained a lower limb fracture 3 months back. So there's a history of fracture and there's gait abnormality. After a detailed evaluation, he was prescribed the splint as shown in the image given below to correct the gait deformity. Which of the following fractures is responsible for the gait deformity for which he is being treated? So in this case, we have to identify the splint first. Only then we will be able to reach the diagnosis. So the splint which has been shown in this condition is ankle foot orthosis brace. It is known as ankle foot orthosis brace. And the indication to use this splint is foot drop. And the diagnosis will also be foot drop. We know the typical gait in foot drop is high stepping gait. So the patient will present with high stepping gait. That means if we are able to identify the splint which has been given in the question, we will be able to reach the diagnosis. And hence, it will be easy for us to guess the correct fracture which has been asked. So in this case, we know that foot drop is caused by injury to the common peroneal nerve. And common peroneal nerve, it winds around the neck of fibula. So whenever there is neck of fibula fracture or fibular fracture, common peroneal nerve is injured. And it causes foot drop. So the answer will be fracture of the fibular neck. And this question has been asked so many times in the previous entrance exams as well. And then coming to the next question, a patient is diagnosed with parathyroid adenoma, was posted for parathyroidectomy. Her pre-operative parathormone was 150 picogram per milliliter, and her parathormone levels fell by 33% at 10 minutes post-excision. What should the surgeon do next? To answer this question, we should know the concept of Miami criteria. So the Miami criteria says that fall in parathyroid hormone should be more than 50% of the maximum preoperative value. That means if we have operated the patient and we have removed the affected parathyroid gland, and simultaneously we are checking the serum PTH level, if it falls by more than 50%, that means we have removed the adequate amount of affected gland. But in case it is less than 50%, that means there's inadequate removal of the gland. As in this question, we can see that parathormone levels, it fell by 33%, which is why the next step would be to convert it to bilateral neck exploration. It suggests that some of the affected gland is still left to be removed, which is why we will have to convert this surgery to bilateral neck exploration because we want to excise the complete tumor, right? So the answer will be option number C. Then coming to the next question, during a laparoscopic cholecystectomy, while dissecting the Calitz triangle, the marked structure is inadvertently injured. What postoperative finding is least likely to be observed in this patient? The options given are ischemia of the right hepatic lobe with elevated transaminases, obstructive jaundice with elevated bilirubin, bile leak leading to bilious drainage and peritonitis, Budd-Chiari syndrome with congestive hepatopathy. So in the given image, we can see that an arrow has been marked. And this arrow represents the Moynihan's hump. Moynihan's hump exactly means that sometimes right hepatic artery, it takes a tortuous course, as we can see in this image. Sometimes right hepatic artery takes a tortuous course, which is known as Moynihan's hump. And during the Callett's triangle dissection, it causes arterial ischemia of the right lobe of the liver, and there are certain biliary complications as well. So this structure is more prone to injury during laparoscopic cholecystectomy. So the marked structure here is right hepatic artery, which is prone to injury. And we know that right hepatic artery is a branch of proper hepatic artery. So it supplies the right lobe of liver, and also it supplies the bile ducts, right? So it says ischemia to the right hepatic lobe with elevated transaminases. This statement is correct. Obstructive jaundice with elevated bilirubin. This happens because of damage or injury to bile ducts. So whenever there's damage to bile ducts, what will happen is it will heal by fibrosis or strictures. And since it heals by strictures, there's going to be bile stasis. And bile stasis will cause elevated levels of bilirubins, and there will be obstructive jaundice. And bile leak can also happen, which can lead to peritonitis and bilious drainage. If we talk about Budd-Chiari syndrome with congestive hepatopathy, it has nothing to do with Budd-Chiari syndrome. So Budd-Chiari syndrome is defined as hepatic venous occlusion, or we can say hepatic venous outflow tract obstruction. So when the hepatic vein will get obstructed, there is going to be back pressure in the hepatic sinusoids, and which is going to result in sinusoidal congestion in the liver. And the patient in this case presents with hepatomegaly and ascites. And chronic cases of Budd-Chiari syndrome, we know that they will progress to fibrosis and eventually cirrhosis of liver. So this cannot be the answer. And also we have to remember that liver is supplied by two blood vessels. One is hepatic artery and one is portal system or portal venous system. But the oxygenated blood to liver comes through right hepatic artery or hepatic artery, which is why there is going to be ischemia of the right hepatic lobe and there will be elevated levels of transaminases. But Budd-Chiari syndrome has nothing to do with injury to right hepatic artery because it is occlusion of the hepatic vein, not of artery. So in this picture, we can see that Moynihan's hump is represented by a tortuous right hepatic artery. And this figure represents two important triangles which can be asked in your exam. One is hepatobiliary triangle, one is Callett's triangle. So if we quickly look at the boundaries of these two, so looking at the boundaries of Callett's triangle, superiorly it is bound by superior border of the cystic artery. So Callett's triangle is bound by superior border of the cystic artery. And then medially it is bound by common hepatic duct. Medially it is bound by common hepatic duct and inferiorly it is bound by cystic duct. So this is the boundary of Callett's triangle. Looking at the boundary of hepatobiliary triangle, superiorly it is made by inferior surface of the liver. So this is the inferior surface of the liver. So this is the inferior surface of the liver, which is making the boundary which is making the superior boundary of hepatobiliary triangle. And medially it is formed by common hepatic duct. And laterally or inferiorly it is formed by cystic duct. And we have to remember that cystic artery is the content of hepatobiliary triangle. And cystic artery is a boundary of Callet's triangle, superior boundary of Callet's triangle. So these are the two triangles which are very commonly asked in the exams. Coming to the next question, a 28-year-old male presents with chronic nasal obstruction which worsens during inspiration. So it is worsening during inspiration and improves when he pulls his cheek laterally. Then, on examination, there is no significant septal deviation or turbinate hypertrophy. Okay. Which is the most likely site of obstruction? So we have to pick up the clues from the question. So there's chronic nasal obstruction. It worsens during inspiration and it improves when he pulls his cheek laterally. This sign is known as Cottle's sign. So there is no septal deviation and no hypertrophy. The site of a obstruction we have to identify. So we should know that internal nasal valve is the most common site of highest nasal resistance. And internal nasal valve collapse. So in case of internal nasal valve collapse, there's nasal obstruction, which worsens during inspiration has been given in the question, which is a kind of dynamic complex, right? So it's a dynamic collapse and it improves when the cheek is pulled laterally, which suggests the Cottle test is positive. So in this case, the answer will be internal nasal valve. And we should know that internal nasal valve is formed by two structures. It is formed by nasal septum medially and it is formed laterally by upper lateral cartilage. So laterally it is formed by upper lateral cartilage. And the angle between these two, that is nasal septum and upper lateral cartilage, it is a very small angle, that is 10 to 15 degrees only. And when there is even small reduction in this angle, so this can significantly increase the airflow resistance. So small reduction can increase the airflow resistance significantly. Coming to the next question. A 30-year-old female with generalized myasthenia gravis presents with predominant bulbar symptoms. She is found to have MuSK antibody positive despite treatment with pyridostigmine and immunosuppressive therapy. Symptoms persist. Okay, so the family inquires about surgical options. What is the most appropriate advice regarding thymectomy? So the patient is having myasthenia gravis with MuSK antibody positive, and the disease is not controlled by pyridostigmine and immunosuppressive therapy. So the family is seeking a surgical options if there's any. So we should know about one trial, that is MGTX trial. It says that we know that MuSK positive myasthenia gravis has respiratory weakness and the patient presents with bulbar symptoms. And the trial was conducted, and this trial found out that MuSK positive, which is purely having ocular symptoms, does not have any benefit after doing thymectomy. So thymectomy has no role in patients who are MuSK positive. And also thymectomy has no role in seronegative myasthenia gravis. So if we look at thymectomy, no role in MuSK positive myasthenia gravis and seronegative myasthenia gravis. So what are the indications for thymectomy in this case? Or this trial says that thymectomy is indicated in patients having acetylcholine esterase antibody positivity. So the patients who are having or who are positive for acetylcholine esterase enzyme or antibody, they are candidates for thymectomy. And also patients who are not having thymoma, that is non-thymomatous patients with acetylcholine receptor positive generalized myasthenia gravis. It also improves the outcome in this disease and also reduces the requirement for steroids. So the two indications for thymectomy are patients who are positive for acetylcholine receptor antibody, and the second indication is non-thymomatous patients who are positive for acetylcholine receptor antibody having generalized myasthenia gravis. But but thymectomy has no role in patients who are having MuSK-positive myasthenia gravis and who are seronegative myasthenia gravis cases. Coming to the next question, which of the following changes occurs with Aliskiren therapy? So Aliskiren, we know that it is a direct renin inhibitor. So we will look at the normal action of renin first. We know that renin is responsible for converting the angiotensinogen to angiotensin 1. And later on, angiotensin 1 is converted to angiotensin 2 by the ACE enzyme. That is angiotensin converting enzyme, right? And renin acts on this site. It inhibits the renin. That means aliskiren is inhibiting the conversion of angiotensinogen to angiotensin 1. So what is going to happen? There is going to be decreased levels of angiotensin 1 and angiotensin 2 as well. And there's going to be accumulation of angiotensinogen. And normally what happens, the angiotensin 2 has a negative feedback on renin. When there's enough of angiotensin 2 in the body, it inhibits renin through a negative feedback loop. But now, when aliskiren is acting, there's already decreased level of angiotensin 2. That means there is no one to inhibit renin. This feedback loop will be lost. So in this case, what will happen? The plasma renin concentration will increase. So what are going to be the consequences of this drug? There will be decreased level of angiotensin 1 and angiotensin 2. And also there's going to be decreased level of plasma renin activity, even though renin is present in more than sufficient amounts, but it is enzymatically inactive. It cannot act. And then the concentration of plasma renin will increase. That means there will be increased concentration of plasma renin. So looking at these options, we can see that in option number 2, there's decreased plasma renin activity, there's decreased level of angiotensin 1 and angiotensin 2, and the concentration of plasma renin will increase. Hence, option B is the correct answer. Then coming to the next question, which says a test is done to check the immediate sign of death, where fingers fail to show congestion distal to a ligature applied at their base. What is the name of this test? So the test that they've been asking is ligature test. In this test, what happens? The finger, they fail to show congestion distal to a ligature applied at their base. If we are applying a ligature at the base of finger, usually in a normal person, there's going to be congestion above the site of ligature. But in case of a dead patient or a dead person, so is not going to happen. So Magnus test is also known as ligature test. And it is a test for confirming the cessation of circulation, body body is lacking circulation. And the other test that they have mentioned is diaphanous test. It is also a test for confirming the cessation of circulation. It is basically a trans illumination test. In this test, basically what we are doing is there will be failure to show redness in the web space between the fingers on trans illumination, on putting a light source from behind. So in a normal person, when we are shining the light from behind of the web space, there's going to be redness. But in a dead person, this test will be negative. And then there's the ECARDS test. It is also a test for cessation of circulation. So in this test, what we do is fluorescent dye is injected at a given site in the body. In a normal person, this dye will produce a color, but in a dead person, fluorescent dye will not produce any color. Any discoloration rather. Then coming to the Winslow test. So Winslow test is a test for confirming the cessation of breathing. It is not a test for cessation of circulation. So in Winslow test, it is a very simple test. What we do is we keep a bowl of water on the chest of the person. If there is no movement, this test is positive. And there are two other tests which are used for confirming the cessation of breathing. The second one being the feather test. In this test, what we do is there's no movement of a feather held in front of the nose. So a normal person would be breathing. And if we keep a feather in front of his nose, the feather is going to move because of the air coming out of the nostrils. And then there's mirror test. So if we keep a mirror in front of a normal person's mouth, the mirror is going to turn dim, or there will be moisture on the mirror because of breathing. But it does not happen in a case of dead person. Coming to the next question, what is the primary function of this instrument? So the first step will be to identify the given instrument. So the given instrument is crescent blade. If we look at the uses of crescent blade, so it is used to create scleral tunnel in a cataract procedure known as SICS, that is small incision cataract surgery. Also, it is used in case of lamellar corneal dissection. In lamellar keratoplasty. And very important, it is used in pterygium surgery. Basically, it helps to separate the head of pterygium. And the last use is limbal dermoid excision. So looking at the options, the option B is the correct answer. That is to create a lamellar scleral tunnel. If we look at the other options, option A says to enter anterior chamber. We do not use crescent blade to enter the anterior chamber. We are using keratome or MVR blade. So for this case, we are using a keratome. And for capsulorhexis, capsulorhexis means we are tearing the anterior lens capsule. For this case, we are using cystotome. It is also known as capsulorhexis forceps. Again, to make a side port incision, we are using the same instrument, that is MVR blade. So this was about question number 60. Then coming on to the next question, that is 61. So this question says a 51-year-old female with type 2 diabetes mellitus is considered for rosiglitazone therapy. Which of the following is not a recognized adverse effect of this medication? First of all, we have to identify this medication, that is rosiglitazone. So it belongs to a group known as PPAR gamma agonist. And it essentially, and these drugs, they essentially enhance the insulin sensitivity. They increase the insulin sensitivity. And the two drugs, or two very important drugs in this class, are pioglitazone and rosiglitazone. So now we'll look at the options. So which of the following is not a recognized adverse effect? First option is congestive heart failure. So congestive heart failure is caused due to these drugs because of plasma volume expansion. And also there's increased risk of fracture in women. New onset macular edema. This side effect is also caused due to fluid retention in the body. Looking at the option number C, hepatotoxicity with elevated transaminases. This is the incorrect side effect of this drug. On the contrary, drugs like rosiglitazone and pioglitazone, they are actually associated with lowering of the transaminases, and which is why they have been used in hepatic steatosis, that is fatty liver. So this is not a side effect of these drugs. So we have to remember that these drugs are also used in NASH, that is non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Basically, what these drugs do, they reduce the hepatic lipid accumulation, and also they decrease the inflammation. So the incorrect option would be option C. That is, they do not produce hepatotoxicity with elevated transaminases. On the contrary, they are used to reduce the transaminases. Looking at the question number 62, the duration of which of these stages of sleep is increased in obstructive sleep apnea? So first of all, we will have to identify the stages of sleep in the given graph. So option 1 represents, or labeling 1 represents REM, that is rapid eye movement sleep, and 2 represents NREM1. Labeling 3 represents NREM2, and labeling 4 represents so labeling 3 represents NREM3 and labeling 4 represents NREM4. And we know that in obstructive sleep apnea, what happens is the stage 1 of non-REM sleep will increase, sorry. So in this case, what will happen? The stage 1 of NREM sleep will increase. And there will be decreased duration of stage 3 and 4. So they are asking about increased. We know that duration of stage 1 will increase. Hence, the correct option would be second one. And few more important point about OSA, that is obstructive sleep apnea. The patient will have increased daytime sleepiness. And there is going to be decreased tone of muscles of the pharynx. Which will cause upper airway obstruction. And there will be cessation of breathing. So what we want to say is that there's going to be increased daytime sleepiness, but the overall duration of sleep is not going to be reduced. And also, since there is reduced tone of muscles of pharynx, so there will be upper airway obstruction, and the patient will experience brief episodes of apnea lasting for about 10 seconds. Then coming to the option, question number 63, it says that a 28-year-old male consumes alcohol on his own at a bar. When he returns home, his father questions him regarding his alcohol addiction. The man gets agitated and assaults his own father. Which among the following BNS sections renders the son responsible for his action? The important clue in this question is to identify that the person has consumed the alcohol on his own will. Nobody has forced him to consume the alcohol. So we'll look at the options one by one. So looking at the option C first, which says BNS section 21. So it deals with offense committed by a child. It states that nothing is an offense which is done by a child whose age is more than 7 years and less than 12 years, because the child has not attained sufficient maturity to judge the nature and consequences of his conduct on that occasion. The child cannot distinguish between right and wrong, which is why he is not liable for punishment. And looking at the BNS section 22. So BNS section 22 is very important. It is nothing but McNaughton's rule. And we know that McNaughton rule says that nothing is an offense which is done by a person who at the time of doing it by reason of unsoundness of mind is incapable of knowing the nature of the act. Then coming to option A, which says BNS section 23. Now this is important. BNS section 23 is for involuntary intoxication. That means a person commits an act under intoxication and the alcohol has been administered without their knowledge or against their will or any other substance. So they are not criminally responsible. In BNS section 24, it is voluntary intoxication. That means the person has consumed the alcohol under his own will and he's liable for the punishment. So in this question, they have given the clue on his own, which is why the correct option would be BNS section 24. Had it been the person was intoxicated by somebody else, in that case, the correct option would be option A, that is BNS section 23. Then coming to the next question, that is question number 64. Which wave of JVP corresponds to point D in the given left ventricular pressure volume loop? So we have been given left ventricular pressure volume loop volume is on x-axis and pressure has been represented on y-axis. So we'll look at all the points step by step, looking at the point A. So at this point, mitral valve opens. And this path from A to B represents the period of filling. And this point A represents end systolic volume. And there's passive filling of the left ventricle. During this entire phase, this is known as end diastolic volume. And at point B, mitral valve closes. Now the ventricle has received all the blood from the left atrium. Now what is going to happen? There's going to be isovolumetric contraction. Isovolumetric contraction. That means the volume of blood inside the ventricle will remain the same, but the pressure is going to increase. At point B, we can say that the volume is remaining the same, but the pressure is escalating. And at point C, the pressure becomes so much that the aortic valve opens. And then there's period of ejection from point C to D. That means all the blood is ejected out from the aortic valve from point C to D. And at point D, what will happen? Once the entire blood has been ejected out, the aortic valve is going to close down. And once the aortic valve closes down, the pressure will come down tremendously, as we can see. So the volume is remaining the same in left ventricle. The volume of blood in the left ventricle will remain the same, but the pressure is going to be coming down. This is known as isovolumetric relaxation. So they are asking the wave of JVP which corresponds to point D. So the JVP wave which corresponds to point D will be the V wave of JVP. And we know that V wave represents atrial filling during ventricular systole, and it peaks at the second heart sound. So at this juncture, we are going to get the second heart sound. So second heart sound will be seen at this juncture, which corresponds to the V wave of JVP. That means there will be atrial filling during the ventricular systole, and it peaks at the second heart sound. So the correct option would be option number A. Coming to question number 65, Raju, a truck driver, presented with complaints of cloudy vision while driving at night for the past couple of months. On examination, his eyes had the following appearance. Which among the following underlying condition is the most likely cause for his vision problem? So this is a very direct question. It shows snowstorm appearance or snowflake cataract. Snowstorm appearance or snowflake cataract. It is seen in diabetes mellitus. Correct answer would be option number D. Now we will also look at few of the other important images which can be asked in your exam. So this represents sunflower cataract. And sunflower cataract is seen in Wilson's disease or chalcosis. Wilson's disease or chalcosis. So these are the two conditions where we can see sunflower cataract. And this is a very classical image showing Christmas tree cataract. It is seen in myotonic dystrophy. Coming to the last image, it shows rosette-shaped cataract. It looks like a flower, which is why we call it rosette-shaped cataract. And it is seen in blunt trauma. Coming to the next question. A pregnant woman at 9 weeks of gestation comes to the clinic. You do a bimanual examination by placing two fingers of one hand in the anterior fornix of the vagina and fingers of the other hand over the abdomen and behind the uterus. The abdominal and vaginal fingers, they seem to oppose below the level of uterus. So which is this sign? So in Hager's sign, we perform the bimanual examination where two fingers of one hand are placed in the anterior fornix of the vagina and fingers of the other hand, which are placed over the abdomen and behind the uterus. And these two fingers of two different hands will oppose below the body of uterus. So this sign can be seen between 6 to 10 weeks of gestation. Looking at the other options, Palmer's sign is nothing but regular and rhythmic uterine contraction during the bimanual examination. So the keyword will be regular and rhythmic contraction on doing the bimanual examination. And Osiender's sign, it is increased pulsation felt through the lateral fornix. And Goodell's sign, it is the softening of cervix. So Goodell's sign is seen by 6th week of gestation. Osiender's sign is seen by 8 weeks of gestation. And Palmer's sign is also seen between 6th to 8th week of gestation. Coming to the next question. Which of the following best describes the disaster management approach adopted by the National Disaster Management Authority, or NDMA? It is abbreviated as NDMA. So the approach which has been adopted by NDMA can be defined as proactive and multi-sectoral. It is defined as proactive and multi-sectoral. Proactive means there are 4 phases in a response to disaster. The first one is prevention and mitigation. So prevention and mitigation, these measures are taken before the disaster has happened. So prevention and mitigation, this happens before disaster. And then response. Response means the action which is taken during the event. So it will be during the disaster. And then there will be prevention and then there will be recovery and rehabilitation. So recovery and rehabilitation phase, they happen after the disaster has happened. So by saying that they are proactive and multi-sectoral, proactive means they are mainly concerned with prevention and mitigation phase. They want to be ready for any kind of disaster. And by saying multi-sectoral means there's a coordination among multiple government departments, NGOs, and community participation, which is why we call them proactive and multi-sectoral. Coming to the next question, an intern in ICU decides to insert a central venous catheter through a femoral vein in a burns victim patient to administer IV fluids. However, while inserting the needle, he accidentally injured the solid structure lying immediately medial to the femoral vein, lying within the femoral sheath. So the structure is present medial to femoral vein and it is present within the femoral sheath. So which of the following drains into the injured structure? So the first step would be to identify the structure. So if we look at the femoral sheath, suppose this is the femoral sheath that I am making. This is going to be the femoral artery, which is red in color, and this blue structure is femoral vein. And this orange color structure which are present here, these are lymph nodes. So the arrangement of the structure is as follows. On the lateral side, we have the femoral artery. So this is femoral artery which is present on the lateral side. And on the medial side, the medialmost structure is lymph nodes. And these lymph nodes have a specific name, lymph node of Cloquet or Rosenmuller. Lymph node of Cloquet or Rosenmuller. So while inserting the needle in this femoral vein, the intern has injured these structures, that is lymph node of Cloquet. And we know that glans penis, it drains into the lymph node of Cloquet. So the answer will be option number B. Looking at the other options, scrotum drains into superficial inguinal lymph nodes. And if we talk about testes or ovaries, they drain into para-aortic group of lymph nodes. Hence, the option B is the correct answer. Coming to the next question, anti-larval measures are being taken for a pond in village. Which of the following synthetic insecticides are not recommended for such measures? Fenthion, chlorpyrifos, DDT, or abate. So DDT is not recommended for anti-larval measures. So DDT, we know it is used for adult mosquitoes, not larvae, which is why it has no role in controlling the larvae of mosquitoes. There's another compound which is known as HCH or lindane. So DDT and lindane, they both are organochlorine compounds. And they are used to control the adult population of mosquitoes. We are not using these substances because they have a risk of water contamination. And also, these compounds have long residual effect, which is why option C is the correct answer. Fenthion, chlorpyrifos, abate, and even malathion. These are effective larvicides. Coming to the next question. A 12-year-old male presents with knee pain following a twisting injury while playing football. He complains of locking and clicking in the knee joint. On examination, performing the test given in the image produces a painful click on external rotation of tibia. This is the most important clue which has been given. So the patient has had a twisting injury to the knee while playing football. Knee joint is locked and there is painful click on the external rotation of the tibia. What is the most likely diagnosis? So this is a classical example of medial meniscal injury and also the test which has been given in this case is McMurray test, which produces a painful click on external rotation of the tibia. So this test is known as McMurray test. So this is an example of, or this test is used to detect an injury in medial meniscus. And if we talk about meniscal injury, so among medial and lateral meniscus, medial meniscus is more commonly injured. Why? Because medial meniscus is less mobile. It is less mobile because it is attached to surrounding structures. For example, it is attached to medial collateral ligament, which renders it less mobile, and hence it is more susceptible to injury and rotational stress. Had the question been, there was painful click on internal rotation, then the answer would be lateral meniscal tear. Coming to the next question, a screening test for a disease has sensitivity of 90%. So sensitivity is given 90%, specificity is 95%. The prevalence of the disease is 10%. And if a person tests positive, what is the probability that they actually have the disease? So basically, they are asking us about the positive predictive value. So positive predictive value means the probability that a person actually has the disease, given that the test result is positive. This is how it is defined. So we have been given three parameters: sensitivity, specificity, and prevalence. To solve this question, we need to know the Bayes theorem. And Bayes theorem says that positive predictive value is equal to sensitivity into prevalence divided by sensitivity into prevalence plus 1 minus specificity multiplied by 1 minus prevalence. So sensitivity is 0.9, specificity is 0.95, and prevalence is 0.1. If we substitute these values in the given formula, specificity is and 1 minus. So this will give us around 66.7%. The positive predictive value will be 66.7%. The formula that we have to remember for this question is Bayes theorem or Bayes formula. A patient is able to perceive two dissimilar images separately in each eye without fusion. This corresponds to which grade of binocular vision? So first of all, we should know that there are three grades of binocular vision: simultaneous perception, fusion, and stereopsis. So simultaneous perception is the first grade. So this actually means that we are able to perceive two dissimilar images simultaneously, one formed on each retina. For example, in this case, if the right eye is shown a dog and the left eye is shown a cage, right? The patient sees the dog inside the cage, and this indicates the simultaneous perception. So this image will be formed on right retina, this will be on the left, and these two images will give a simultaneous perception, that is dog inside the cage. And the second grade is fusion. So it is the ability to combine two incomplete but similar images into a single one. For example, in this image, we can see that rabbit is not holding anything. And then in the second image, the rabbit is holding a flower in his hand. So when we combine or fuse these images, it results into a single image, that is fusion. And stereopsis basically means the ability to perceive depth. due to binocular retinal disparity. So it is related to depth. So in this case, a patient is able to perceive two dissimilar images separately in each eye without fusion. So it is without fusion. So this is going to be simultaneous perception. Coming to the next question, a patient who recently underwent peritidectomy. A patient who recently underwent peritidectomy presents with flushing, sweating, and a burning sensation on the left side of the face during a meal. Injury to postganglionic parasympathetic nerve fibers of which of the following nerves can result in this? So the clue is flushing and sweating and a burning sensation on the left side of the face during a meal. So when a person is eating, there is flushing and sweating on the cheek, on the left side. So this is classical finding in gustatory sweating or Fraze syndrome. So in Fraze syndrome, what happened? During parotid surgery, because of trauma, while opening the parotid capsule, there is damage to the autonomic innervation of the salivary gland. So when we are doing parotidectomy or any other parotid gland surgery, there is damage to the autonomic fibers which are innervating the parotid gland, right? So what happens after the injury has happened? The parasympathetic nerve fibers, they will abnormally grow into parotid gland. So as a result, whenever there is stimulus for salivation or the person is eating something, there is sweating and flushing which occurs due to aberrant innervation of the sweat glands and the cutaneous vessels on the skin. So this is known as Frey syndrome, which is because of aberrant innervation of the parasympathetic nerve fibers into the parotid gland. So diagnosis we have already made, it is Frey syndrome. The test which is used to diagnose this condition is starch iodine test. Starch iodine test. So what happens when we paint the affected area with iodine? It eventually turns blue in color due to exposure to sweat. So this is the basis of starch iodine test. So the management in this condition will be to use antiperspirants such as aluminium chloride, or we can also use botulinum toxin. And surgical procedures have also been used, such as tympanic neurectomy or avulsion of the auriculotemporal nerve. So this is the nerve which is affected in this condition, and we have to identify the nerve from the given figure. So starting with the topmost, so the nerve which has been labeled as B is maxillary nerve. And the nerve which has been labeled as D is auriculotemporal nerve. And nerve A is posterior auricular nerve. And C represents inferior alveolar nerve. So auricular temporal nerve is represented by the option D. Hence the correct option would be option C, that is nerve which has been labeled as D. Coming to the next question, it says that identify the safety measures present in cylinders used in the anesthesia workstation. So this is a very easy question, and the given image represents pin index safety system. It represents pin index safety system. It is a safety mechanism which is used on gas cylinders to ensure that only the correct gas cylinder can be connected to the corresponding yoke on an anesthesia machine. You can see in this image, so this is anesthesia machine and this is a gas cylinder. So because of the different configuration which is present on different gas cylinders, it ensures that the correct gas cylinder will be connected to the corresponding Yukon anesthesia machine. So option B will be the correct answer. Question number 75. An autopsy is being performed on the corpse of a 50-year-old HIV patient. So the clue is the patient was HIV positive. The forensic medicine resident uses a technique of in situ dissection combined with en bloc removal of organs. The technique is known as, so this is a previous year NEET PG question. So HIV infected patient, and also there's in situ dissection. This classically represents Rokitansky technique, and Rokitansky technique is used in patients who are affected by highly contagious disease such as HIV and hepatitis B. So in this technique, what we do in situ dissection and we do en bloc removal of the organs. Hence, option B is the correct answer. So looking at the other options, in Workhouse technique, the keyword is going to be organs are removed one by one from the body which has to be examined. So in this case, the cranial cavity is opened first, and then spinal cord, then thoracic, and then abdominal organs. So organs are removed one by one. This is going to be the keyword. Rokitansky technique we have seen, it is in situ dissection used in patients who are having highly contagious diseases such as hepatitis B or HIV. Looking at the Gons technique, the keyword is going to be en bloc removal. That means the thoracic, cervical, pelvic, and abdominal organs will be removed as organ blocks. For example, thoracic block, pelvic block, and abdominal block. Then coming to the Letulais technique, the keyword is going to be en masse. That means thoracic, cervical, abdominal, and pelvic organs are removed en masse, meaning we will remove a one big block. And the advantage is we can examine the entire body in less than 30 minutes because the removal of organs is very quick or relatively quicker in this technique. Coming to the next question, a 42-year-old male came positive for Mycobacterium tuberculosis on CBNAT. A CT thorax was acquired. What does the marked finding on the CT given indicates? So this CT clearly shows that there's tree in bud appearance. So it looks like a tree having buds. So this finding we have identified, it is tree in bud appearance, which represents the endobronchial spread. Had they asked us about the hematogenous spread, we would see miliary tuberculosis or miliary pattern on the chest X-ray. Talking about the lymphatic spread, in case of lymphatic spread, there is going to be thickening of interlobular septae. And in case of fibrotic sequelae, we will see cavities in the lungs. Coming to the next question, a 32-year-old patient with a history of unsafe CSOM, that is unsafe CSOM, presents with severe headache, high-grade fever, chills, and rigor. A CECT scan of the brain was done, and the findings are shown below. What is the clinical feature not expected in the above-mentioned scenario? So the sign that we can see on the given CT is the sign that I'm highlighting in yellow is it is known as empty delta sign. Since this is a contrast enhanced CECT, we will see a empty delta sign. And the patient in this case is having lateral sinus thrombophlebitis. as he's having high-grade fever, chills, and rigor and headache. And the sign is also suggestive of lateral sinus thrombophlebitis. So it is intracranial complication of the CUSOM, or rather the unsafe type of CSOM. So what happens, the thrombus, it may get infected and it can lead to septic thrombophlebitis. And the patient classically presents with high-grade fever, known as picket fence fever. That means spiking fever with chills and rigor. And also the patient is going to have severe headache as given in this question. And there's going to be foul smelling ear discharge. So looking at the option A says picket fence fever with chills, true. So picket fence fever classically means the fever is spiking with chills and rigors. And there's going to be papilledema as well on fundus examination. Grisinger's sign is going to be positive. That means the edema will be present over mastoid area. The reason being because of emissary vein thrombosis. And lateral rectus palsy has nothing to do with this condition. So the management in this condition will be, we will give the patient IV broad spectrum antibiotics. And we will do mastoidectomy to remove the source of infection. So looking at deltas in the radiology, so empty delta sign on contrast enhanced CCT is seen in cerebral venous thrombosis. And also delta sign on NCCT, that is non-contrast CT, is seen in cerebral venous thrombosis. And pseudo delta sign on NCCT is seen in subarachnoid hemorrhage. And double delta sign on MRI is seen in meniscal bucket handle tear of meniscus. So empty delta on contrast enhanced and delta sign on non-contrast CT. Coming to the next question, that is, a 28-year-old footballer presents with sudden collapse during a match without trauma. So there's sudden collapse. He has history of exertional dyspnea. History of exertional dyspnea is given, and intermittent dizziness. There's family history of sudden cardiac death. Auscultation reveals S4, ejection systolic murmur, STT changes on ECG. Doppler shows the following characteristic findings. What is the most appropriate immediate management in this case scenario? So if we look at the Doppler, there's one classical finding which has been given. The Doppler is dagger shaped. It looks like a dagger. And it is seen in left ventricular outflow tract obstruction. And we know that in hypertrophic obstructive cardiomyopathy, there's dynamic obstruction. There's hypertrophy of the left ventricle, or rather, there is asymmetrical septal hypertrophy, which results in dynamic LVOT obstruction. So there is going to be LVOT obstruction because of asymmetric septal hypertrophy. The Doppler will show dagger-shaped finding, and the patient will have exertional syncope. Also, there's going to be difficulty in breathing, that is dyspnea, because of diastolic dysfunction. There's going to be angina because of microvascular ischemia. and there's going to be S for gallop. This S for gallop is because of forceful atrial contraction in a ventricle which is non-compliant. And the classical murmur will be ejection systolic murmur. And HOCM is very classically associated with sudden cardiac death in young patients or young adults. So they are asking us the immediate management. First option says intravenous nitroglycerin infusion. So this option is incorrect because nitroglycerin infusion will cause venodilatation. It will cause venodilatation, and venodilatation will decrease the preload. Already preload is less. If we are giving nitroglycerin, it is going to worsen the condition. Second option is rapid IV fluids bolus followed by beta blockers. So this is the correct option. We want to increase the preload. That's why we are going to give IV fluids to the patient with beta blockers, or we can also give non-dihydropyridine calcium channel blockers like verapamil and diltiazem. Third option is immediate administration of digoxin. Digoxin we know is a positive inotrope. It will increase the contractility of the heart and it will worsen the obstruction or left ventricular outflow tract obstruction. It will make the condition even more severe. Last option is emergency synchronized cardioversion followed by diuretics. So this is done in patients who are hemodynamically unstable. So patients having hemodynamically unstable arrhythmias. And also if we give diuretics, there is going to be fluid loss from the body. And this fluid loss is going to decrease the preload and hence it will worsen the condition. So the best would be to give rapid IV fluid bolus followed by beta blockers or non-dihydropyridine calcium channel blockers such as verapamil or diltiazem. Coming to the next question, a 32-year-old pregnant woman who's presented with vaginal bleeding, abdominal pain, and severe episodes of vomiting was diagnosed with complete molar pregnancy. On transvaginal ultrasonography, the following finding is seen in a left ovary. How would you proceed with the management of this patient? So in this case, the figure represents theca lutein cyst. So usually what happens, these theca lutein cysts, they tend to regress spontaneously in a period of about 2 to 4 months after we evacuate the molar pregnancy. Once the molar pregnancy has been taken out, these cysts will eventually automatically disappear or regress. So sometimes what happens, these cysts can undergo torsion and the patient will present with pelvic pain. In that case, we are doing laparoscopic untwisting of the cysts. But usually we do not do anything for the cyst. So the best option would be suction and curettage. That is option number C. And if we talk about option number A, which says unilateral oophorectomy with dilatation and curettage, so it is not indicated as the patient has no evidence of ovarian torsion. Had there been some evidence of ovarian torsion, we would have gone for oophorectomy. Looking at the option number D, hysterectomy with bilateral oophorectomy, this is done in patients who have completed their family and also there are signs of ovarian torsion and labor-induced evacuation is not done or it is rarely done because there's increased blood loss during this procedure and it increases the risk of development of persistent trophoblastic disease. Question number 80. A patient with nephrotic syndrome has severe proteinuria and low levels of serum albumin. What would be the most likely change in the anion gap of this patient? We know that albumin is responsible for about 75% of the, so albumin is responsible for about 75% of the unmeasured anion. And we know that in nephrotic syndrome, there is hypoalbuminemia. So this is going to result in decrease in the level of unmeasured anions. Coming to the next question, a data set of serum triglyceride levels is in a population shows a long right-sided tail. So there's a right-sided tail as we can see with a few extremely high values. Which of the following statement is incorrect regarding this distribution? So if we look at examples of few distribution first, then we will solve this question. So this is a normal bell-shaped curve. And these are skewed distribution. So in image A, we can see that the tailing is present towards the right side. It is very much similar to the image which we have been given in the question. The center depicts the mean. And as we go from right to left, it depicts median and then mode. So in this case, we can see that in right skewed distribution, mean is greater than median, median is greater than mode. This is the finding. In case of left skewed distribution, the tailing is present towards the left side. And we can see that median has the max, in this scenario, we can see that mode has the maximum value followed by median, then mean. So here mode is more than median, then mean. And in case of bimodal distribution, we can see that there are two modes and mean and median are similar. That means mean is equal to median, but they are not equal to mode. So coming back to the right skewed distribution, which we have been asked in the question, in this case, mean is going to be the maximum, then median, then mode. So the first option is the majority of the observations lie to the right of the mean. This is a wrong statement. The distribution is positively skewed, correct statement. The mean will be greater than the median, yes. In this case, mean will be more than median and it will be more than mode. Median is a better measure of central tendency than mean. Yes, this is also a true statement. So when a distribution is skewed, the mean is no longer represents the central location accurately. Because in case of a skewed distribution, the mean gets distorted by outliers, which is why median remains stable. That's why we are saying that median is a better measure of central tendency compared to mean. So option A is incorrect. Coming to question number 82. Rajesh, a construction worker, presented with redness and watery eyes. He was started on topical steroids for allergic conjunctivitis. So the patient was given topical steroids. 4 months later, he was presents with similar complaints. Fluorescence staining has been revealing the following finding and identify the lesion. We can see that this image represents ulcers which are geographically shaped. So this is known as geographic ulcer. So the given figure represents the geographic ulcer which is caused by herpes simplex virus. And they have also given a trigger in the question or trigger for the condition in the question that HSV related geographic ulcer is caused by a trigger such as topical steroids that the patient earlier used for allergic conjunctivitis, which possibly reactivated the virus in this patient. And the patient developed the following condition, that is geographic ulcer. And staining, this is also very important. They have used the fluorescence staining in this patient. So fluorescence stain is orange in color and it absorbs blue light. Blue light has less wavelength. And once it absorbs blue light, the lesion or the ulcer appears green in color because it is emitting a green light which has got higher wavelength. That's why we are seeing green shape, green color, geographic ulcer. So there are two viral keratitis where we use topical steroids. One is interstitial keratitis. In this condition, we are using topical steroids. And one is disciform keratitis. So in interstitial keratitis, there's defect in the stroma, corneal stroma, and it is a type 3 hypersensitivity reaction. And in disciform keratitis, there's type 4 hypersensitivity reaction. So these are the two conditions where we are using topical steroids. In rest of the viral ulcers, topical steroids are contraindicated. Question number 83, mirtazapine referred to as NASA. Which of the following best explain this designation? So this drug, mirtazapine, is a atypical antidepressant or it is a newer antidepressant. The abbreviation NASA means noradrenergic and specific serotonergic antidepressant. So the mechanism of action is it is enhancing the release of norepinephrine and serotonin by alpha 2 receptor blockade. It is blocking the alpha 2 receptors. And also it selectively blocks the 5-HT2 and 5-HT3 receptors. So it is blocking the 5-HT2 and 5-HT3 receptors selectively, and by blocking the alpha 2 presynaptic auto and hetero receptors, it is increasing the level of norepinephrine and also it is increasing the level of serotonin. And the use of this drug is very important since it is an antidepressant. So it is used in patients with having depression. And also the side effect of the drug is sedation. So it is the drug of choice in patients with depression and insomnia because this drug is causing sedation as a side effect, and we are exploiting this side effect as a use in patients with depression and insomnia. So the another drug which can be used in patients with depression and insomnia is Myasthenia. So looking at the option, it inhibits monoamine oxidase A and B, increasing the norepinephrine and serotonin levels in the CNS. Incorrect. It selectively blocks serotonin reuptake while enhancing dopaminergic activity in the limbic system. Incorrect. It enhances norepinephrine and serotonin release by alpha 2 receptor blockade and selectively blocks 5-HT2 and 5-HT3 receptor. This is correct. It primarily increases dopaminergic and adrenergic neurotransmission via postsynaptic receptor agonism. This is also wrong. Coming to the next question, a 26-year-old female is evaluated for a strong family history of malignancy. Her mother was diagnosed with colorectal carcinoma at 35 years of age. Genetic testing confirms a mutation in the gene MSH2, Link syndrome, and she is currently asymptomatic. What is the most appropriate next step? So the thing that we have to remember is in patients who are having MLH1 and MSH2 mutation, the screening has to start by 25 years of age. And we will also do endoscopic surveillance every 2 years. So endoscopic surveillance or endoscopy will be done every 2 yearly, and the screening has to start latest by 25 years. So this patient is already 26 years old. So the screening should start immediately in this patient. So the most appropriate next line management would be start colorectal screening now, not every 5 years, every 2 years. and begin screening at 35 years, this is wrong, at 25 years. And prophylactic colectomy is not indicated. So types of Link syndrome, there are two types, Link 1 and Link 2. So Link 1 syndrome is associated with colon cancer. And it is Link 2 syndrome is associated with colon cancer plus extracolonic cancers. The extracolonic cancers could be carcinoma of the endometrium, carcinoma of the ovary, etc. Coming to the next question, a patient presents to the outpatient department with progressive skin changes over the lower leg. There's a recent history of deep vein thrombosis, and Doppler evaluation further reveals perforator vein incompetence with only obstruction. Based on the CEAP classification, how should this condition be classified? So the image shows a condition known as lipodermatosclerosis. Image shows lipodermatosclerosis. And the cause of this condition is deep vein thrombosis. Doppler has been done, which has shown there is obstruction and perforator vein incompetence. So if we look at the CEAP classification, so clinical classification will be C4B. C4B corresponds to atrophy blanchia or lipodermatosclerosis as shown in this figure. C4A is pigmentation or eczema. C4C is corona phlebitica. So clinical classification we have figured out. It is C4B. Then coming to the etiological classification, they have said that this has occurred after deep vein thrombosis. So the cause is given. It is secondary in cause. So it is C4B and ES. And then coming to the anatomical classification. So there's perforator incompetence. So perforator incompetence makes it, there is deep vein thrombosis. So this results in AD. So ADES C4B. And pathophysiologic classification tells us about there is obstruction and thrombosis. So it will result in PO. So the correct option will be option number C, that is C4B, ES, AD, and PO. Identify the instrument given below. The instrument which has been shown below is a Lane's tissue forceps. It is a direct question. And we know that Lane's tissue holding forceps, they have a very stout and thick blades. And oval fenestrae or openings are present in the blade. And it is used to hold bulky and tough structures, such as lymph nodes. If we look at the other instruments, Alley's forceps, so the distal blades are toothed. They have teeth, as you can see. This is the key finding to look at. And also there's lock which is present in the proximal part, and it is used to hold the skin, flap, fascia, and the bladder wall. Looking at the Babcock's forceps, so the distal part is curved, as we can see. And the fenestra or the opening is triangular in shape. Unlike the other two where the fenestra opening, unlike the Lane's forceps where the opening was oval in shape. So this is the distinguishing feature. And also there's a lock which is present on the proximal part of this forceps. Babcock's forceps is used to hold the tubular structures like fallopian tube, appendix, ureter, etc. And the last instrument is sponge holding forceps. They are used to clean the skin with betadine before starting the surgery. And also it is used to hold the fundus and Hartmann's pouch of the gallbladder during cholecystectomy. Coming to the next question, which among the following options acts as a cofactor for the enzyme involved in the given reaction below, which forms a part of the free radical scavenging system? So we can see that there is formation of hydrogen peroxide, and the enzyme which is involved is superoxide dismutase. And they are talking about mitochondria. So the enzyme involved in the given reaction is superoxide dismutase, for which manganese is acting as a cofactor. The option will be the answer will be option C, that is manganese. So the superoxide dismutase, it helps in the conversion of superoxide ions into hydrogen peroxide. And if we talk about the cytosolic SOD, it is dependent on copper and zinc, whereas mitochondrial is dependent on manganese, M for mitochondria and M for manganese. So mitochondrial SOD is dependent on manganese, M for mitochondria, M for manganese, and cytosolic SOD is dependent on C for cytosolic and C for copper and zinc. Coming to the next question. A 58-year-old man is admitted to the ICU with severely elevated blood pressure. Blood pressure is 210 by 130 millimeter of mercury, headache, and blurred vision. Fundoscopic examination reveals retinal hemorrhage. The physician decides to start an intravenous drug that rapidly lowers the blood pressure by causing vasodilatation and is used only for short term, that is less than equal to 48 hours. Which of the following drugs is the most appropriate? So the diagnosis, as we can see, the patient is having retinal hemorrhage and also the blood pressure is more than 180 by 120. So the diagnosis will be malignant hypertension. And the drug that they're talking about is phenoldopam. So the answer will be phenoldopam. Phenoldopam is a selective. So phenoldopam is a selective D1 receptor agonist. It is a selective D1 receptor agonist. And it causes arteriolar vasodilatation. When there is arteriolar vasodilatation, there is going to be decrease in the systemic vascular resistance. And there is going to be decrease in the blood pressure. And also at the same time, it is going to improve the renal blood flow as well. It will improve the renal blood flow as well. Because during hypertensive emergencies, such as malignant hypertension, the kidneys are prone to injury. Mechanism of action we have already seen, it is D1 receptor agonist. 36-year-old female patient is posted for lap cholecystectomy. She forgot the instruction of being nil per oral. So the patient is not nil per oral and had breakfast few hours back. The anesthetist decides to use the device shown in the image given below to reduce the risk of gastric aspiration. Identify the device. This is definitely laryngeal mask airway, but we have to specifically define which type of LMA is this. So the given image shows LMA supreme. So the cuff design is modified in this case, and there's a drainage tube that allows for gastric access, and also there's an integrated bite block and a fixation tab. As we can see that this is the airway tube, and the tube which is present behind is the drain tube, and this is the fixation tab. And this is the bite block. And this part is the pilot balloon. So the answer is LMA supreme. If we look at the other types of LMA, so proceal laryngeal mask airway or LMA proceal, the this one. So it is also a second generation reusable supraglottic airway. So there is also a presence of drain tube, that is gastric drain tube, a bite block and a cuff. But how we can distinguish it from the supreme airway is that there is no fixation tap. So the fixation tap is absent here. That is the key point to be remembered to distinguish it from LMA supreme. And classic laryngeal mask airway, which has been shown in this image, and it is the most widely used type of supraglottic device. So it does not have any ports for gastric access. As we can see, there's only one tube which is present, that is airway tube. So it does not have a separate port for gastric access. And there's fast trash laryngeal mask airway. So this also enables endoscopically guided intubation. The distinguishing feature is that it also has a handle and a connector, apart from an endotracheal tube insertion port. Coming to the question number 90, which of the following is an incorrect statement regarding the plant in the image given below? We can very easily identify the plant. The plant is Digitalis purpura. So we have to select the incorrect statement. First statement is it can cause urticaria as a skin manifestation. True. Activated charcoal is contraindicated in this poisoning caused by ingestion. False. Activated charcoal is indicated in the poisoning by Digitalis purpura. The roots, leaves, and seeds of the plants contain toxin. Yes, all the parts of the plants, be it root, seeds, or leaves, they all are toxic. Its toxicity can present as visual manifestation. Yes, the visual manifestation that they're talking about is xanthopsia. That is the yellow discoloration of the vision. And also it causes photophobia and blurring of vision. And activated charcoal can be used in the poisoning of in the poisoning of Digitalis purpura. And also, there's a specific antidote which is present for this condition is digibind. It is digibind. And the toxic compounds which are present in the plant are digoxin, digitonin, and digitalin. Coming to the next question, a 20-year-old girl, while playing in the ground, was bitten by a snake. The people present near the ground clicked the photo of the snake. So we've been given the picture of the snake and to what family this snake belongs to. We have to identify the snake and classify it accordingly. We can see that in the given picture, there are double white bands which are present on the body of the snake. So it is a common crate. It is a common crate. And common crate, it belongs to the family Elapidae. So cobra and crate, they come in the family Elapidae. Viperidae has viper snakes such as pit viper and Russell's viper. And we have to also remember that cobra and crate, they are neurotoxic, whereas vipers are V for vipers, they are vasculotoxic. And Hydrophilidae includes sea snakes. So we'll look at few of the important images. So in this figure, we can see that there is a hood which is present. on the body of the snake. So this is common cobra. So common cobra has a hood. And in the next image, we can see there's no hood which is present. So this is a king cobra. So king cobra does not have a hood. And in the next image, we can see that there are 3 rows of diamond-shaped black or brown spots which are present. So diamond-shaped spots are present on the body of the snake. It is viper, or rather Russell's viper. Next question. Which of the following lab or radiological findings is not suggestive of histoplasmosis? Tiny oval yeast cells measuring 2 to 4 micrometer with narrow-based budding on direct microscopy. True. There is narrow-based budding in histoplasmosis. That is true. Pulmonary infiltrates with hilar lymphadenopathy on chest X-ray. True. Culture revealing yeast forms at 25 degrees Celsius. No. So yeast forms are seen as creamy white colonies at 37 degrees Celsius, not at 25 degrees Celsius. Presence of histoplasma antigen in the urine sample. True. So we know that histoplasma is a dimorphic fungus. That means it exists in 2 forms. So the mycelial form or the mold form exists at, the mold form or mycelial form will exist at 25 degrees Celsius. And the yeast form will exist at 37 degrees Celsius. And in this image, if we zoom in, we can see that there's narrow budding yeast which is present. And it causes Darling's disease. And disseminated histoplasmosis is seen in patients who are having low CMI, that is cell-mediated immunity is compromised in those patients. They are prone to disseminated histoplasmosis. And if we look at the mycelial or the mold form, which is seen as 25 degrees Celsius, so these are spherical spores as we can see. And there are some tubercular projections which are present on the outside. And the yeast form, we can see narrow budding yeast. Coming to the next question, which of the following conditions match the following conditions with the color of the postmortem staining they produce? So we know that bright pink is produced by hypothermia and dark purple is produced due to asphyxia. So option 3, B and 4A, there's only one option which matches the following. So pale bronze is present in Clostridium belchi septicemia. And brownish red is present in methemoglobinemia. Option D is the correct option. And also, we have to remember that carbon monoxide produces cherry red color. Coming to the next question, which of the following statements is false about positron emission tomography, computed tomography, and CT? So PET-CT, enhanced whole body CT is followed by whole body PET imaging. True. It combines cross-sectional anatomic information from CT scans with metabolic information of PET scans. True. So the anatomic information will be obtained from CT scan, that is computed tomography, and metabolic information from the positron emission tomography. Imaging is done after administration of oral glucose solution. No. No oral glucose solution is given in this case. And strenuous activity must be avoided prior to imaging. True. So the isotope or the proton emitting isotope that we are using is fluorine 18 FDG, fluorodeoxyglucose. The half-life is 110 minutes. And this is an important question. The principle of PET scan is dual photon peak at 511 kilo electron volt. That means when a positron emitting nucleus emits a positron, it collides with electron and there is annihilation reaction. This annihilation reaction will produce two photons which will go in the opposite directions at 500 and kilo electron volt, and these will be detected by the scanner, and hence they produce the metabolic images. Looking at the option D, strenuous activity must be avoided prior to imaging. Yes, if the patient is doing strenuous activity before the imaging, the muscles will become metabolically active and they will take up active, all the fluorodeoxyglucose, and which will give a false positive result. So looking at the action of FDG when it is given in the body is, so when we give the patient fluorodeoxyglucose, it first goes into the blood, the FDG, and then it is taken up by the cells through GLUT receptor. We know that glucose can be metabolized from glucose to glucose 6-phosphate by hexokinase, but so is not the case with FDG. Hexokinase does not convert FDG. Hexokinase converts FDG into FDG phosphate, which cannot further be metabolized. But the normal glucose which is present inside the cells, it is further metabolized by the process of glycolysis. So what happens is FDG is eventually entrapped in the cells in the form of FDG 6-phosphate because it cannot be further metabolized. Looking at the question number 95, a 29-year-old priming gravida, 18 weeks of gestation, there is acute lower abdominal pain. Diagnosis is uterine fibroid prior to pregnancy. On examination, uterus is enlarged to the corresponding gestational age. There is localized tenderness, no vaginal bleeding, heart sounds are present. Ultrasound shows a live intrauterine fetus with 6 centimeter intramural fibroid. Most appropriate management will be, so the given features, they point towards the red degeneration of fibroid. And we know that in red degeneration of fibroid, only conservative management and bed rest is advised. There's no need to do immediate myomectomy or termination of pregnancy or elective hysterectomy. So in this case, the patient will be advised to do conservative management with analgesics to relieve the pain and bed rest. Which of the following enzymes of the liver is upregulated in the well-fed state? We will look at all the enzymes one by one. We know that glycogen phosphorylase, it is an enzyme for glycogenolysis. And glycogenolysis happens in starvation. So the patient is already well-fed. So this cannot be the answer. Looking at the second option, carnitine palmitoyl transferase 1. It is involved in beta oxidation of fatty acids. And this is also seen in starvation. Looking at the third option, that is protein kinase A. So protein kinase A is involved in both glycogenolysis as well as gluconeogenesis. So this cannot be the answer. Looking at the last option, fatty acid synthase. This is the correct answer. In well-fed state, fatty acid synthase is upregulated in the liver and it is involved in the synthesis of fats. Looking at the question number 97, a patient has normal fluency and repetition of speech. So fluency is normal, but repetition of speech is also normal, but impaired naming and comprehension. So when comprehension is impaired, we think of Wernicke's aphasia. But this is not a case of Wernicke's aphasia, because in Wernicke's aphasia, comprehension is affected, and also there's a repetition which is affected. Naming is also affected, but fluency remains preserved. So looking at the options one by one, posterior transcortical aphasia. So this is the correct answer, posterior transcortical aphasia. So in posterior transcortical aphasia, what happens is there is impairment in the comprehension, but repetition is preserved contrary to the Wernicke's. And also naming is affected and fluency is preserved. In Broca's, what happens? Comprehension is preserved, repetition is impaired, and naming is also impaired, and the fluency is decreased. And in anterior transcortical, what happens? The comprehension is preserved. It is similar to Broca's, except for repetition. Repetition is also preserved here. And also, naming is affected and fluency is also affected. In global, everything is impaired. In global aphasia, everything is impaired. And if we look at the anomic aphasia, comprehension is preserved, repetition is preserved, naming is impaired, fluency is present. So this is a case of posterior transcortical aphasia. How it is different from Wernicke's aphasia is that repetition in posterior transcortical aphasia is preserved, whereas in Wernicke's aphasia, repetition is affected. And Broca's and anterior transcortical are related to each other, except for the repetition part. So, a 6-month-old baby is being investigated for recurrent vomiting and failure to thrive. Lab tests reveal hyperammonemia and increased urinary excretion of orotic acid, uracil, and glutamine. The following disorder occurs due to the defect at. So, the clue that they have given is there's urinary excretion of orotic acid, uracil, and glutamine, and the child is having hyperammonemia. So, we know that in type 2 hyperammonemia, there is elevated levels of ammonia in the blood, and it is due to the deficiency of the enzyme, that is enzyme number 2, which is ornithine transcarbamylase deficiency. It converts carbamoyl phosphate and ornithine into citrulline. When this enzyme is deficient, there will be accumulation of carbamoyl phosphate, and this carbamoyl phosphate will go into the pyrimidine synthesis, and hence there will be increased levels of orotic acid or increased excretion of orotic acid. So the answer will be option number B. Coming to the next question, a 31-year-old male from a rural community presents with a gradual onset of abdominal distension. So there's ascites or abdominal distension, there's hepatomegaly, there's jaundice, that is mild icterus. Similar complaints are reported among multiple individuals in the same locality. That means the infection is not limited to only one person. Dietary history reveals consumption of locally sourced unprocessed millet. The flowers of the contaminant seeds in the food grains are shown below. What is the most likely diagnosis? So the plant which has been shown in the image is Crotalaria. And this Crotalaria, it contaminates the millets and it results in a condition known as endemic ascites. Ascites is fluid accumulation in the abdomen as they have given in the clue. There's abdominal distension and there's hepatomegaly and also jaundice. So the toxin responsible for this condition is pyrrolizidine. The name of the toxin is pyrrolizidine or pyrrolizidine alkaloids. So Crotalaria or Junjuna, seeds, they are contaminating the millet crop, and hence they result in hepatic veno-occlusive disease causing portal hypertension and ascites. So the answer will be endemic ascites. In epidemic dropsy is caused by argemone oil or sanguinarine toxin, and it results in bilateral edema, cardiac failure, and erythema. There is no hepatomegaly and ascites in epidemic dropsy, and ergotism is caused by claviceps purpurea. And aflatoxicosis is caused by aspergillus toxin. So aspergillus toxin, we know that they are hepatotoxic and they can also result in hepatocellular carcinoma. So what is the effect on resting membrane potential when the serum potassium level is 3 milliequivalent per liter? We know that normal level of the serum potassium is 3 to 5 milliequivalent per liter. In this case, the patient is having hypokalemia. In this case, the patient is having hypokalemia. So if we look at the normal cell, so in normal cell, a gradient is present. We know that potassium is present in more amount inside of the cell compared to the lesser amount which is present outside the cell. So there's a gradient which is established across the cell. So more potassium, it tends to move out when the gradient is present, and it is responsible for the resting membrane potential of the cell. But in case of hypokalemia, what will happen? The amount of potassium which is present outside will be lesser. Hence, more potassium will move out of the cell. So the gradient will widen and there's going to be increased movement of potassium out of the cell. So the RMP in this case will become more negative. So inside of the cell become more negative. When inside of the cell becomes more negative, there is hyperpolarization. And we know that in case of hypokalemia, the gradient becomes larger and wider. So more potassium tends to leave the cell and it makes it more negative towards the inside, hence causing hyperpolarization. So if we look at the question, options, RMP becomes more negative, cell is more excitable, no. RMP becomes more positive, cell is more excitable, no. RMP becomes more negative and cell is less excitable, yes. The excitability is explained as, imagine if the normal cell is having the RMP of 70 millivolt and the threshold is minus 55 millivolt. That means the cell has to cross a barrier of or a path of 15 millivolts to reach the threshold, and then the cell will be excited. But in case of cell having hypokalemia, the RMP is already increased. For example, it becomes minus 80 here. So in that case, the threshold will remain the same, but the cell will have to travel more path, that is of 25 millivolt to reach the threshold, which is why we say that the cell is less excitable because the cell has to travel more path to reach the threshold potential of minus 55. That's why option C is correct. So here I'm concluding the part 2 of Grand Test 15 that we have discussed. Thank you.